Good afternoon and welcome. I'm Cynthia Borge. I'm a general surgeon with interest in upper GI and bariatric surgery. I'm also a regional surgical advisor, or RSA, of the Royal College of Surgeons of Edinburgh. I cover the area of London. I hope you are enjoying this series of webinars from the RSAs of the college. We would like to thank the college for the opportunity to present to you today. There are well over 40 RSAs. We are consultants and fellows of the college and provide advice and support at a local level in the United Kingdom. If you want to get in touch with one of us, please look at the college website for further details. Today's topic is managing upper GI bleeding. Mr. Vital Rao will be our speaker today. Vital trained in the Yorkshire Deanery and was appointed as a consultant surgeon at the University Hospital of North Midlands in Stoke-on-Trent. Mr. Rao is an honorary lecturer at Keele Medical School and has been closely associated with the Deanery with the delivery of undergraduate medical education program over the last 5 years. He has a keen research interest in bariatric surgery and is a faculty for courses of the Royal College, as well as being an RSA. Please remember that during the presentation, you can use the Zoom button to post questions, and we will try to answer as many of them as we can. You can vote with the thumbs up button as to which questions you would like mostly answered. Over to you, Mr. Rao.
Thank you, Cynthia, for your kind introduction. Hello, everyone. Without much ado, I would like to plunge headlong into a very important topic on upper GI hemorrhage. As you all know, this is a very common presentation to any acute surgical service. And in the UK, it usually works like the patient's presenting to the medical department, usually the gastroenterologist, with upper GI hemorrhage. And once they deal with the initial management, if they've got ongoing problems such as recurrent bleed, then the surgeons get involved. So what is upper GI hemorrhage? So any bleed from the gastrointestinal tract proximal to the ligament of Treitz. Now this is a smooth muscle band, as you know, running from the DJ flexure all the way up to the left crest of the diaphragm. So the source of bleed from the esophagus, the stomach, or the duodenum manifests as upper GI hemorrhage. It is one of those true surgical emergencies where rapid assessment, resuscitation, correction of coagulopathy should go hand in hand with definitive intervention to stop the source of bleed. These modalities include endoscopic methods or interventional radiology, and when these two fail, as a last resort, surgery. So what are the causes of upper GI hemorrhage? Can be broadly classified into variceal and non-variceal bleeds. Those from varices account for about 4 to 20%. So what are varices? These are portosystemic shunts which usually occur in the distal esophagus or the proximal stomach against a background of parenchymal liver disease such as alcoholic liver disease, or non-cirrhotic in the case of portovenous occlusive disease or portal vein thrombosis. The other big cause of upper GI hemorrhage includes peptic ulcer disease. This is usually in close association with H. pylori. As you know, about 90% of duodenal ulcers and 70% of gastric ulcers are associated with H. pylori infestation, and also use of NSAIDs. NSAID usage causes a 40-fold increase in gastric ulcers and 8-fold increase in duodenal ulcers. So what happens in these situations? You've got injury to the gastric mucosa, exposing the arterioles and the small blood vessels to the acidic environment, and this then eats away at the arterial walls, causing pseudoaneurysms, and this rupture resulting in upper GI bleed. The other important subset is esophagitis, gastritis, and duodenitis. This usually occur in acutely unwell patients in the intensive care unit as stress esophagitis. And the nice recommendation is that these patients should be on prophylactic PPIs. An important cause is also malarial tears, about 4 to 8%. This is nothing but longitudinal tears which occur in the proximal stomach or the distal esophagus in a setting of vomiting with increased intragastric pressure, usually associated with alcohol binges. Tumors, especially in the late stage, about 4 to 8% gastric or esophageal tumors, can present as upper GI bleeds. Rare causes include diaphragm lesions or vascular ectasia, which is nothing but normal arterioles which are exposed to the acidic environment. A very rare but very serious outcome of an infected graft following a repair of abdominal aortic aneurysm called the aortoenteric fistula, where it fistulates into the duodenum or into the proximal small bowel, resulting in torrential hemorrhage. Surgery is the only way we can correct this, and this is with high mortality. So also hemophilia, blood in the bile, occurs after interventional procedures such as ERCP or stents in the hepatobiliary system. So how do they manifest? They manifest typically as melena. Those who have managed upper GI bleeds can watch that they can be led by their noses towards the patient who has got an ongoing upper GI bleed in a ward. The typical black tarry stool have got a peculiar smell. So also hematemesis, bright red vomiting. Coffee ground vomiting. This is more often with upper GI hemorrhage because of the effect of acid on the hemoglobin. These patients inevitably have got a significant hemoglobin drop. And in cases where there is rapid and significant hemorrhage, the patients can present with PR bleed. So it goes without saying that any patient with PR bleed should have an upper GI endoscopy to rule out an obvious source in the upper GI tract. So as part of your assessment, you've got to ask about the character, the frequency, and the volume of blood loss. So also associated symptoms such as pain, nausea, or vomiting. Also past medical history, particularly for liver disease, history of alcohol abuse, history of peptic ulcer or malignancy. Drug history, especially for NSAIDs, steroids, anticoagulants, especially antiplatelets, aspirin, clopidogrel, so also warfarin, heparin, the new kids on the block, which is the novel oral anticoagulants, such as apixaban and rivaroxaban. You also have to sort of assess the patient clinically by looking for stigmata of chronic liver disease, such as palmaerythema, or spider nevi, or capimedicine. And you're going to do a PR examination just to make sure what kind of bleed the patient is having. So how do you go about managing these patients? It's mainly the classical ABCDE, the airway, the breathing, the circulation, discipline, exposure. Beware that these patients can have reduced level of consciousness, particularly in patients with alcoholic liver disease because of a degree of hepatic encephalopathy. So you've got to be aware of the risk of aspiration of gastric contents or blood in these patients. So you've got to alert your anesthetic colleagues, and while you wait for them, you can use simple maneuvers such as head tilt, chin lift, jaw thrust, and use adjuvants such as Giddel or nasopharyngeal airway. In patients with compromised airway or inadequate ventilation, you've got to secure the airway with the help of your anesthetic colleagues. You're going to start monitoring the vital signs such as pulse rate, blood pressure, respiratory rate, and arterial oxygen saturations. Needless to say, you've got to get vascular access by means of a wide bore peripheral venous access, at least 2 16 to 18 gauge cannulae. Got a sense of some urgent blood tests for full blood count, USNEs, LFT, coagulation, arterial blood gas, and at least cross-match 4 units in a case of significant upper GI bleed. Now, these blood tests will guide you as to the possible cause of the upper GI hemorrhage. Raised urea is typically associated with upper GI hemorrhage and tends to differentiate that from a lower GI hemorrhage. This is because the hemoglobin and the immunoglobulins get metabolized into blood urea nitrogen and they get reabsorbed, resulting in raised urea levels. Acidosis on a blood gas is a surrogate marker of mortality, and this gives you an indication of the adequacy or inadequacy of tissue perfusion. Significant hypertension, however, is a late sign, and you should really make sure that you adequately resuscitate the patient before we reach this end stage. So for resuscitation, it's better to follow the ATLS guidelines to assess what kind of hypervolemic shock the patient is having. So if I draw your attention to the slide, just look at this. A patient can afford to lose about 1.5 liters of blood before and still have a normal blood pressure. So blood pressure per se is not a reliable sign for the degree of hypovolemic shock. And this ATLS guideline will help you in assessing what class of hemorrhagic shock the patient is having to appropriately guide your resuscitation. So initial fluid resuscitation with crystalloids, however, in the case of significant hemorrhage, blood products is better advisable. So early liaison with your blood bank or a hematologist will help you in determining the blood products to be used. We all are moving towards the concept of permissive hypotension. There's no point over-resuscitating the patient by pumping in bloods or blood products or crystalloids. You've got to just achieve that level of blood pressure to maintain critical tissue perfusion until you have source control, that is, you switch off the tap. So in a case of massive upper GI hemorrhage, trigger the major hemorrhage protocol. And this is mainly about trying to stop the ongoing bleed and at the same time resuscitating the patient. So you give Paxil and FFP on a 1:1 ratio with platelets and cryoprecipitate as directed by the blood test or by a hematologist. So the take-home message is, at the outset, alert your various teams, your anesthetic friends, your theaters, your endoscopy department, your intensive care, and the hematologist. I would like to reiterate that a normal hemoglobin and a normal blood pressure does not exclude a potentially life-threatening hemorrhage. Now, I'd like to delve a bit on this management of patients with anticoagulants. Now, in the setting of GI hemorrhage, the general advice is to withhold antiplatelets and anticoagulants. However, about a third of patients who are already in the hospital due to some other reason are at risk of developing an upper GI hemorrhage. You get an important subset of patients who actually are within 30 days of coronary stenting or about 90 days of having had an acute coronary syndrome. This is usually on dual anti so the patients are on one quicker control the four-factor prothrombin complex concentrate. In patients with apexal band redoxaban A, which is receptors. If they're not, then a four-factor prothrombin complex concentrate is dabigatran, which does stabilize the viral function. Patients with low molecular weight heparin, the platelets are less than 50, they need platelets bringing them back to normal. Blood indicator fibrinogen less than 1 or a PT, APTT or IN are more than 1.5 can give them FFP, and this is in the setting of active ongoing bleed. Even if after FFP, if the fibrinogen less than 1.5, we can give cryoprecipitate. What about tranexamic acid? The role of tranexamic acid is really not defined as of yet. The ongoing trial called the HALT-IT trial might throw some light, and we await the results of this trial with keen interest. So once you have sorted out the initial resuscitation, you've got to risk stratify these patients. And there are two criteria with which you risk stratify these patients to assess the risk of rebleed and also the ongoing effect of or the ongoing risk of mortality. So in the first 24 hours, before they have got the endoscopy, you use the Glasgow Blast 4 criteria, and this uses mainly some blood tests, some vital parameters, and the past medical history. And any patient with a score of more than 1 are deemed to be high risk, and I can assure you most of these patients are. The second criteria is after the endoscopy. That's the post-endoscopy Rockall score. And that takes into parameters such as the age, the vital parameters, and also the endoscopic picture. And any patient with a score of more than 2 are at risk of rebleed. So let us embed the principles which we have discussed so far in the management of some patients. So presenting to you a case study, a 45-year-old male known to have alcoholic liver disease and found collapsed at home, brought by the ambulance crew to A&E with a history of hematemesis. So on assessment, you find the patient to be drowsy, the Glasgow Coma score of 10, tachycardic, hypertensive, with worrying respiratory signs. You do a quick blood gas, hemoglobin is 5 with a lactate of 7. What do? So you go by the ABCDE routine, you send some urgent bloods and start resuscitating the patient. Specifically, you give splanchnic vasoconstrictors, considering that the patient may be having an ongoing variceal bleed. So octreotide is usually the flavor used in the UK. You can use terlipressin. Now these agents, they divert the blood from the gastrointestinal tract to the vital organs, such as the brain, the kidneys, and the heart, thereby reducing the portal venous pressure. You use prophylactic antibiotics because these patients are at risk of developing infection, particularly chest infection. You give intravenous PPIs, 80 milligram omeprazole bolus with 8 milligram per hour infusion for 72 hours. And it is advisable that the patient should have an endoscopy immediately if they are unstable, or at least within 24 hours of admission in a stable patient. Why do we do this endoscopy? Most of the units have got dedicated bleeder suites. So during normal working hours, they can be done in endoscopy suites. But outside hours, it is recommended that they get the endoscopy in theaters, in the Seaport Theater with anesthetic backup. So when you do an endoscopy, this is what you see. You get a bleed from an ongoing varix. So that's the rubber band. So you go in with the endoscope and you slip in a rubber band at the base of the varix, thereby stopping the bleed. That's called variceal band ligation. This is very effective in varices in the distal esophagus. However, in varices of the proximal stomach, where the access with an endoscope is difficult, you can control the bleed by injecting glue, which is otherwise called N-butyl 2-cyanoacrylate. You can also inject thrombin. In patients who are quite unwell, in extremis, and in the intensive care for organ support, in this situation, if you're going with an endoscope, because of the ongoing rapid bleed, you can't see much because of the blood gushing up. In that situation, you can use the Sengstaken Blakemore tube, which contains 2 balloons, one in the esophagus, one in the stomach. The disadvantage is that this can be used for a maximum of 48 hours, and you've got to deflate it after that because of the risk of causing ischemia and perforation. Nowadays, we have self-expanding metal stents, which can stay in for about 14 days. Hemospray is a new kid in the block. It's not available for routine use. Now, when the endoscopist goes in first time to control the bleed, we always encourage them to write in the report as to whether, if the patient rebleeds, what is the next best mode of action. Can the patient come back to the endoscopy department for a further re-intervention? Or should we be considering interventional radiology or surgery? In the setting of a variceal bleed, if the endoscopists have written that if the patient rebleeds, there's no point doing an endoscopy, then we subject them to a procedure in interventional radiology called TIPS. This stands for transjugular intrahepatic portosystemic shunt. So what you do is you pass in catheter through the internal jugular vein and then deploy a stent connecting a portal vein radical to the hepatic vein, thereby reducing the pressure of the portal venous system, helping in stopping the variceal bleed. This is usually done in advanced liver centers with IR facilities. So let's go to the second case study. 28-year-old male, known to be on NSAIDs for backache, brought by the ambulance team to A&E Resus with a history of collapse and hematemesis. So on assessment, he's alert, tachycardic, hypotensive with worrying respiratory signs. A quick blood gas reveals a hemoglobin of 6 with a lactate of 4. So what do? Again, similar to the first patient, ABCDE, send off some urgent bloods and start a resuscitative measures, give PPIs and antibiotics, and then you do an endoscopy. At endoscopy, you find a large 4-centimeter ulcer in the first part of duodenum with a visible blood vessel at its base. So what are the modalities available? The recommendation is that you've got to do at least a dual modality, which includes injection of adrenaline and also an application of an endoclip if the blood vessel is visible and bleeding. If it is diffuse, then you use thermal coagulation, either contact monopolar or non-contact argon plasma coagulation with adrenaline. Fibrin and thrombin is also available for treatment. So if you look at the slides, you can see a bleeding from a blood vessel there. You apply the mechanical clips there to control the bleed. And in this setting, usually in the form of stress gastritis, you get a diffuse bleed with a pumping blood vessel there. So you do what is called argon plasma coagulation with a view to achieve control. So this is the Forrest classification, which gives you an idea based on endoscopy as to what is the risk of rebleed. This categorizes the endoscopic findings into 3 categories, and anything above 3 and 2C is at a higher risk of rebleed. And as I alluded to before, we encourage the endoscopists to decide at the first setting as to whether the patient rebleeds, can the patient come back to endoscopy, or should we consider any other modality of treatment. So carrying on with the second patient, the patient is stable post-procedure. However, on day 2, he develops massive hematemesis. And what are the options available here? Now, in this case, this is a real case which happened in our hospital. The endoscopists have clearly said, in view of the big ulcer, he's not for repeat endoscopy. So then the other modalities remaining are interventional radiology or surgery. Now, how do we decide that? If the patient is stable enough, then yes, interventional radiology is the modality of choice. But in our case, the patient was extremely unstable, almost in a peri-arrest situation, so we had to wheel him straight away into surgery. So if the patient is stable, you wheel the patient into an interventional radiology suite, whereby a catheter is passed up the groin, blood vessels onto the aorta, and by what is called selective angiogram, we find out the source of bleed. And as you can see here, there's a blush at the area of the gastroduodenal artery, which is a branch of the hepatic artery. And so this is the obvious source of bleed. So you plug the bleed by putting in coils or gel forms, thereby stopping the bleed. It's got a very high sensitivity and specificity. However, the complications include injury to the blood vessel or ischemia or perforation or contrast nephropathy. Now, if everything else fails, then you go in for surgery. However, you've got to be warned that surgery is associated with a very high mortality of almost 29%. So what do we do in surgery? We go in, we do a crash laparotomy, and then open up the anterior wall of the duodenum. And you're looking at the lumen and the posterior wall, where you can see a big ulcer, and you can see the bleeding blood vessel there. So you secure control by passing in a wide stitch across the base of the ulcer with a heavy stitch, a 1/0 or Vicryl or a 1/0 PDS, and hopefully the bleeding will stop. So to summarize, upper GI hemorrhage is quite a common presentation at acute hospitals with significant morbidity and mortality, with a frequency of 100 per 100,000 of the population annually, and with a 10% mortality. It's one of those true surgical emergencies where rapid assessment, appropriate and targeted resuscitation, correction of coagulopathy goes hand in hand with early intervention in the form of endoscopy and radiology, and if that fails, surgery as a salvage procedure. I would like to thank my colleagues down south who wrote this excellent review article in the journal Surgery, and this was published towards the end of last year. I would strongly recommend each one of you to assess this journal because it addresses quite a few basic surgical topics across a wide range of specialties. Thank you very much for your kind attention.
Thank you very much, Vital. We've had some trouble with the connection when you were describing the anticoagulant slide.
Sure.
So there are several requests for you to repeat that slide, please, Vital,
Sure.
because it's
Sure.
an important one.
Sure. So I mean, anticoagulant, you'll be surprised to know that almost most of these patients who develop upper GI hemorrhage are already on anticoagulants. And my advice to you would be that it would be very worthwhile early on to get appropriate advice from a hematologist with a view to get the proper advice as to how to deal with these patients. Now, there is an important subset of these patients who are already inpatients in the hospital, recovering from an acute coronary event or after having a coronary stent put in. And these patients are usually on dual antiplatelet therapy, clopidogrel and aspirin. So what do you do with them? If they are within the time frame, that is 30 days of coronary stent or 90 days of acute coronary syndrome, the advice is to continue the dual antiplatelet therapy and try to stop the bleed. However, if they are outside this window period, then you can stop the clopidogrel but continue with the low dose aspirin. If the patient is on warfarin, you can reverse the warfarin by using vitamin K. However, if you're going to do it much more faster with a view to facilitate endoscopic intervention or surgery, then you can use what is called a 4-factor prothrombin complex concentrate, which contains protein S and C. If the patient is on the NOACs, that is apixaban, rivaroxaban, and edoxaban, then you've got an antidote called Ondixia. This is a recombinant inactive factor 10A, which acts as a decoy binding the 10A inhibitors to reduce their activity. In the case of dabigatran, you can use a monoclonal antibody called idarucizumab, which specifically binds to the anticoagulant and is metabolized, thereby reversing its action. If the patient is on low molecular weight heparin, usually in vascular surgery patients, then you can use protamine to reverse the effect. Based on your initial resuscitative blood test which you have done, the platelets is less than 50 and the patient is still bleeding, you can give platelets. Similarly, if the fibrinogen is less than 1.5 grams or the PT-APTT INR is more than 1.5, then you can use FFP. Again, in patients with active bleeding. In spite of this, the fibrinogen is still less than 1.5, you can give cryoprecipitate. Again, I would like to stress that it is advisable to get appropriate advice from the hematologist in your hospital. The role of tranexamic acid, it used to be a blind therapeutic modality whereby you usually give tranexamic acid for everyone. We're not exactly sure as to the efficacy of this, and this is a non-halt it trial, and hopefully it will throw some light on the efficacy of tranexamic acid in this situation. I hope that clarifies your queries. Cynthia?
Thank you very much, Vital. We've also had a question about varices and whether things like beta blockers can be used or would be advisable in the acute setting.
Right. Usually what is advised is the splanchnic vasoconstrictors, the octreotide and terlipressin. I'm not aware of beta blockers being used as a standard in every case of varicose bleed. Remember, these patients are usually having multiple medical comorbidities, such as asthma, such as cardiac conditions and comorbidities. I would be advised by my medical colleagues regarding the role of beta blockers in this situation. I'm not aware that beta blockers is a standard treatment pertaining to the ongoing varicose bleed.
We also had a question about intoxication, whether you would do something else if a patient is intoxicated and having an upper GI bleed. I certainly said to the person asking the question that you need to obviously give some time in, make sure that you're trying to prevent the Wernicke-Korsakoff syndrome. And would you add anything else if the patient is drunk or intoxicated?
Yes, we tend to use Pabrinex, which is basically a cocktail of, as I said, thiamine and some micronutrients. But again, remember, it may not be because of intoxication that the patient is drowsy, maybe because of the hepatic encephalopathy, which these patients usually suffer from. And to me, in the acute setting, the most important thing is to secure the airway, because before you realize, you will have the patient choking on their own blood. And in this situation, it's very important to get all support you can get from the anesthetist, from the critical care unit, from the theaters, to secure the airway, and then go in with the endoscope to stop the source of bleed.
Thank you so much. One more question. The indication for surgery, and if you do have a bleeding gastroduodenal artery, what would you use to suture it?
I personally, will go in and use a heavy suture, just a Vicryl or a PDS. The important thing is to stop the bleed as soon as you can, because before you realize, you'll start going on a slippery slope. The patient becomes more coagulopathic, more acidotic, more hypothermic, and you want to kill this triad of death by trying to have source control as soon as you can.
Thank you very much, Vital. I think we'll end it there today. May I remind you all that there is another webinar on the 9th of July, and this is about wound healing this time. It's principles of wound healing and techniques achieving skin cover. Thank you so much.
Thank you. Thanks.